So good afternoon, everybody. I want to welcome you to this exciting webinar titled Emerging Trends in Healthcare Access, brought about by COVID-19. This afternoon, we have a very interesting panel that will be taking us through this topic. I would request all the panelists this afternoon to please attend. Guests can be able to see you. Thank you very much. I'm going to be your host this afternoon. My name is Judy Mugoya. I am the country manager at Uganda, and I will be taking through a brief on our speakers today. On our panel this afternoon, we have Rosalie. She's Managing Director of Zamara Insurance Brokers and strategic growth and expansion of the risk and insurance business across the continent. Rosalind has provided strong leadership in the development of Zamara's strategy, and the business has gained rapid growth and increased market share through a customer-centric approach to business execution and have focus on additional value-added services. The secret to Rosalie is her focus on people. She is a strong believer that to build a successful business, you must build people. Has been steady and sustained growth of Zamara's group market share in Kenya and is set on driving the transformation of economies on the African continent, Zamara's expansion strategy. Rosalind currently sits on the boards of Zamara Kenya, Zamara Rwanda, and the Association of Insurance Brokers in Kenya. Rosalind holds a Master in Business Administration, specializing in strategic management from the University of Nairobi, and a Bachelor of Business Administration in Marketing from Africa Nazarene University. Rosaline is married, is a proud mother of 2 girls and 1 boy. She also comes from a family of 23 siblings. Rosaline, want to come to this Our is Kombe is the Chief Executive Officer and Managing Director at the Metropolitan Hospitals Limited. So Director and Systems Architect at Alliance Management Systems, and before joining Metropolitan Hospital, he was the Managing Director at Investment Management Limited. He is a member of the National Economic and Social Council and chairman of the Kenya Association of Hospitals. To career at Metropolitan Hospital, Dr. Gakombe had roles, and development of the standards agreement and platform between the Association of Kenya Insurers and the Kenya Association of Hospitals adopted in October 2006. He has also helped in the design and development of hospital management software known as AMS 2000, currently in use in Metropolitan and several other hospitals in Kenya. Dr. holds a master's degree in business administration in strategic management and Bachelor of Medicine, a Bachelor of Surgery from the University of Nairobi. Dr. Gakombe, we welcome very much this webinar this afternoon. Our last guest is Mr. Bradford. Mr. Bradford was appointed the Chief Executive Officer and Executive Director of CIPLA Quality on the 6th of November 2013. A graduate of Cambridge University, Nevin has over 30 years experience in the pharmaceutical industry, cutting across consumer health, personal care, branded and generic products. His career profile spans across a range of senior sales, marketing, and general management positions in both multinational and generic pharmaceutical companies in Russia, Indonesia, Saudi Arabia, Africa, China, and Europe. Prior to CIPLA, Mr. Bradford was head of Ranbaxy UK and formerly the managing director of Ranbaxy JV China, Guangzhou. Mr. Bradford spent 17 years at SK, a range of senior roles in Africa as a regional manager, in Saudi Arabia, general manager, in India as the sales and marketing director, and in Russia, marketing director. He has also had stints in Novartis Consumer Health as a general manager and Pharmacia Consumer Health as the area director, Africa, Middle East and Eastern Europe, and EC DeWitt. Ladies and gentlemen, that is the profile of our panelists this afternoon. And indeed, you are in for a wonderful experience. Moderator afternoon is Esther Kiringa, who is Group Director, Smart International Limited. To all our panelists, we wish a very pleasant session this afternoon and receive our warm welcomes this webinar. Esther, over to you.
Thank you, Judy, for that very well introduction. Allow me to acknowledge the participants who have joined us this afternoon. Currently, we are at over 120 participants, so thank you for joining us in. We'll go straight to the topic of the day, where we'll be looking at what are the trends and in the emerging trends in healthcare access brought about by COVID-19. In the last 4 months, since COVID was first reported in East Africa, there has been a drive to adopt innovative solutions to be able to curtail the current pandemic. One of the key things which has been on a rise is the adoption of telemedicine, where now we see members preferring to just call a doctor at their homes and get virtual treatment. So we'll be looking at and diving into what are the other emerging trends that are brought about by COVID, and how well is or are we prepared to ensure that these innovative features actually outlive the pandemic. So our first guest speaker is Rosalind Mugo, who will take us through a session on the emerging trends. For all our participants, please feel free to engage our guest speakers through the chat, and we will be able to read out your questions, your queries to our guest speakers for their response. Allow me to introduce Rosalind, to just share the screen, have the presentation. Rosalind, welcome. Rosa, your mic is mute.
Yes. Okay, I'm now unmuted. Thank you very much. Thank you for that introduction, Judy. Mine will be brief, and I will, because I belong in the insurance industry, I will try and take an insurance angle to the healthcare emerging trends. All right. Our focus today will be on dynamics in healthcare access. We will discuss how the healthcare access has been repositioned by both the consumers and the service providers. We will then talk about the insurance response and look at various opportunities for both employers and the public at large. All right, so COVID-19 has created an economic crisis alongside a healthcare crisis. The pandemic has threatened to overwhelm the healthcare system on matters COVID, but on the other hand, we have seen that the demand for non-COVID cases has gone down. The entire healthcare ecosystem has been altered to accommodate this pandemic, as we have seen community-based measures being proposed. So COVID-19 has come to expose the much needed changes that we need in our healthcare systems. So historically, people have said that healthcare has been relatively immune to recessions. So people get sick during good or bad times. The demand for healthcare has been known to be relatively consistent. However, I think this is a fallacy, and I do believe that healthcare, as much as any other industry, is hit by recession. And even worse, I think it takes longer for the healthcare industry to bounce back. So what we'll do today, we're going to look at 3 drivers of decrease in demand of healthcare access. We have what has been out in the public arena, the government-driven drivers, where they have curtailed movements through lockdowns and curfews. We also have the Ministry of Health directives on ways of working. We then have the employer-driven causes, where we now have an economic downturn, and because of that, organizations are letting people go. So a lot of people have lost employee-sponsored insurance covers. We also have employers trying to sustain costs and cutting off some of these things that are deemed unnecessary. So there's largely reduced spending. We then have people-driven causes. There's aversion to going to hospitals because of risk of contamination. We have seen a lot of people putting off surgical procedures and elective procedures. And the overall impact has been poor management of chronic diseases and an increase in mental health and substance abuse. I'm not sure we have taken time to think about the emotional strain that has come with social isolation. A lot of things are coming out from just that part. So all these things have been a big contribution to the low numbers that we are seeing when it comes to healthcare access. But on the other hand, we have seen a slight increase of demand because of COVID treatment. ICUs and HDUs are said to be full. And I'm afraid that the situation might get worse, especially with economies opening up. We're likely to see an upsurge of these cases. So what are some of the things that people are doing? There's been a complete shift in how people have interacted with healthcare. One of the coping strategies has been by way of home care treatments. The very concept of home care is now very rife, now more than it has ever been. So 5 months into the crisis in our very own country, what are we seeing? We are seeing our healthcare system has spoken about the rising caseload and the possibility of home care, home-based care for mild cases. And I believe this is going to continue for a while with most people working from home. We have home care delivery is seen as convenient because people do not like the hospital queues or just the risk of being in hospitals at such a time. I think home care has always been an option worth exploring pre and during Corona. It's misunderstood, whereas there are very many benefits that we can draw from it. So we have the obvious advantages that come with home care. Drug delivery programs that help individuals with chronic conditions who have to manage their health and stick to certain drug protocols to prevent escalation. We also have the risk of contamination is eliminated. And we have also enabled wise usage of insurance benefits. In the past, insurance benefits have been known to be used for acute ailments, flus and colds mostly. But right now, people are only using the insurance benefits when they must. I do know that there's a downside to it because there's a lot of self-medication. People are using Dr. Google to come up with responses to their health problems. And sometimes you need, the critical cases do need more. However, this is just to let everybody know that insurance does cover home care treatment. What varies is the limits, and sometimes normal exclusions apply. But this is the one benefit that we haven't seen people who are covered by insurance taking advantage of. Right? So I think the next question is, what is the future of healthcare systems and how prepared are they? So taking this into in account, we have seen service providers being forced to reinvent and re-engineer themselves. We find ourselves in exceptional situations during this crisis. So in trying to respond to this shock, many countries have discovered that their very own healthcare systems are very fragile. So some of the things that we're going to be forced to do, we're going to have to reevaluate our healthcare supply chains, and we're going to have to get proper funding. There is a lot of push and call to the government to do more when it comes to budget allocations on matters healthcare. There's a lot of fear of cutback of foreign funding because a lot of countries are beginning to look inward. There's also been a very clear shift of who the aid recipient is when it comes to healthcare. So some of the countries which were considered as underdogs are now actually giving healthcare aid. There's also the interaction with the environment. It has been questioned, and this is going to take time before people begin to appreciate it. There's been accelerated use of technology and telemedicine. We have seen a lot of things come up on that front. And some of the things that we would have, that this technology has come to sort of help us with they have come to sort of resolve some of the issues that come with a strained healthcare system. You will find that the use of these technologies will only expand as we now resolve issues that we experience in healthcare even before COVID. So some of the things we were grappling with were healthcare providers were very few, we had inadequate budgets, and we had a very weak healthcare system. But these technologies can help us get closer to our goal of universal health coverage. So telemedicine is helping us reduce exposure. We now have virtual consultations, which are being able to provide triage care. So for very simple ailments, you do not have to leave your home. We have also seen a lot of dashboards for logistic management systems, which are helping disseminate essential resources. We now have smart apps for contact tracing. We are now able to track persons in our proximity who have been infected by COVID-19. So the big question is, what role has insurance played during this pandemic, and how responsive have they been? So the role of insurance is very clear, and it addresses many functions. I'll highlight five functions of the role of health insurance. I do admit that as an industry, we need to work harder in making sure that there's compatibility between the five roles. And the five that come to mind are financial protection of individuals with catastrophic health events, broad access of cover for very little. We expect insurance to negotiate better pricing with service providers. We expect that they should do more in ensuring the quality of clinicians and hospitals. And we also have insurance companies should actively nudge individuals towards staying healthy. So what have we seen in terms of this response? We have seen a mixed response when it comes to this pandemic from insurances. This is mostly at a global level. It's been very difficult for insurance to determine the impact. So each country and each continent seems to have been impacted differently. Insurance would ordinarily use mortality and morbidity to determine pricing of a particular risk. So in this case, we don't have too much. We don't have too much to go with. It is a case that we're calling unprecedented. It's a wait and see situation, and a lot of underwriters are making do as they go. So far, they have been quite accommodating to the various requests that have been made, and we have a very active regulator who's very involved in this issue. And this now takes us back to a very similar situation we had as a country when we had our very first terror attack. Terrorism was new, it was unheard of, and it was what we called a standard exclusion. But with time, underwriting of this risk has improved, and now terrorism is a standard inclusion. So terrorism is covered no matter what. We do not have it as an exclusion anymore. It is, however, evident that the crisis is going to force insurance companies to transform and rethink pandemics as a whole. We've been having the right conversations on treatment protocols, service providers, and treatment costs. And I believe with time, we will have very well thought out solutions on pandemics and management of the same. International insurance seem to have done very well, better than the local insurance in addressing the pandemic, even though the premium costing is quite high and a little inhibitive, I'll be honest, especially for the general public. So it's been said before that in our country, without insurance, a person is one illness away from poverty. I must say it is quite a shame. We need to do more to ensure affordability of insurance covers, while at the same time improving the general healthcare system. So ours as intermediaries, what have we done? We've continued to push boundaries. We have taken these conversations a notch higher. We are having conversations on innovative solutions, including coverage of the less affluent and the remote population. There's also a big population of senior citizens that we need to rethink the offering. We don't have too many insurance companies giving solutions for the senior citizens. And even those that are giving are very inhibitive when it comes to age caps and some of the conditions that are covered. So we are asking and we are demanding more from insurance companies. We are saying remove the age caps, ensure inclusivity of various conditions when it comes to pandemics. So what we have seen in the recent past is an appreciation of medical insurance during this period. The cost of treating coronavirus has been very prohibitive and even more costly for those with underlying conditions. Those who have lost their employer-sponsored insurance covers are reaching out to us for individual covers. We also have an increased uptake of covers for senior citizens. So we have a lot of people who want to take insurance for their parents. And then also several corporates are doing a lot to ensure that there is adequacy of cover for their employees. And I think this is going to be on the increase in the next few weeks because the economy is opening up and the exposure is going to be that much higher. So finally, the way forward for employers is a deep look into your employee assistance program. What does it address? Do you have a chronic disease management program? Do you have a mental health policy and a program that works very well? There's also been a very clear call from the government where WIBA is no longer an option. WIBA is Work Injuries Benefit Act. If you view the government's occupational safety and health post-COVID-19 return to work policy, the government has been very clear and every employer must obtain WIBA policy to ensure coverage of occupational diseases and exposure to COVID-19. Right, so Esther, that is my submission.
Thank you so much, Rosa. A very powerful presentation there. I can see we have a number of questions coming in, but before I go to the question, probably for you, Rosa, given what you've taken us through, I just have a question in terms of, is there a likelihood to increase enrollment of the medical for the uninsured? With this pandemic result to, currently we are 2.8% penetration in this market.
Yeah.
Is there a likelihood that now with COVID, we'll see an upsurge of members now running to get medical cover?
All right, that's a very good question. So there's the people who might lose their employer-sponsored covers, health insurances. And for those people, we're already seeing an increase in discussions when it comes to coverage of, when it comes to individual coverage. So people are reaching out to us and asking, can I take a cover on my own? But then there's less people interested in what we call luxury covers. Yeah, so people want to know, if I take a healthcare solution, what is it going to cover? Now we are getting into very interesting conversations. People want to know, does my coverage extend to pandemics? Does my coverage extend to chronic ailments? In the past, there's been a lot of focus on outpatient and less focus on the intrinsic inpatient benefits. Organizations, on the other hand, are also those that are capable or are able are ensuring that their employees are well taken care of. Again, the other lots that we have seen an increase in terms of uptake of insurance is the senior citizens. A lot of people are now taking insurance covers for their parents. Yeah.
Thank you for that, Rosa. Allow me to take one question from the audience, our participants, especially on the item of home care. And somebody is asking, what is home care treatment? How does the doctor come to your house, or is it a particular panel of only approved doctors who can be able to carry out home care?
All right, so it's very similar to the concept of going to hospital. So the very same treatment you'd have gotten in a hospital or in a clinic, you would get it at home, right? So you transfer, the only difference is the location, right? So this, more often than not, is not for critical cases. I must issue that disclaimer. A lot of doctors are hesitant in treatment of critical cases in homes. This is for acute ailments, and insurance companies, what they provide for is that it should be the same panel you'd have, and they would transfer that care that you'd have had in hospital at home, right? So it works the very same way that it would if you were visiting a service provider.
Thank you, Rosa. There's so many questions coming in, and I know we'll be able to tackle them at the tail end.
Okay.
Thank you for that. I would want to bring in our second guest speaker to speak to us about the topic. That is Nevin Bradford. Nevin, welcome.
Thank you. Good afternoon, everybody.
Good afternoon.
I'm speaking to you from Luzira, a suburb of Kampala. So I'm the CEO of Cipla Quality Chemicals, which is East Africa's largest pharmaceutical manufacturer. So I'd like to share a few thoughts with you this afternoon on how COVID has impacted the provision and manufacture of medicines in East Africa and more broadly across sub-Saharan Africa. Now, even prior to COVID, we are in a situation where, for example, 60% of the world's HIV/AIDS patients are in Africa, but less than 5% of their HIV medicines, known as antiretrovirals, treat this 60% of the world's patients are manufactured in Africa. 60% of the patients, less than 5% of the ARVs, excluding South Africa. And if we turn to malaria, the situation is even more, the disparity is even greater. On the continent here, we have over 80% of the world's malaria patients annually, and less than 4% of the malaria medicines, treatments, artemisinin-based combination therapies, and others are manufactured on the continent. So in both cases, HIV and malaria, over 95% of the medicines used to treat these diseases, these illnesses, are imported. In the normal state of events, a normal course of events, this is not a great challenge. However, what COVID has exposed is a huge potential security of supply issue in Africa. Supply and logistic lines from India and China and elsewhere, whilst operating smoothly for most of the time, when we enter a challenging period such as COVID, have proven to be not as robust as had been the case before. We, as an African-based manufacturer, and our peers in other countries in the pharmaceutical industry, are manufacturing, in Africa for African patients. And the security of supply issue is thereby mitigated. It doesn't mean it has entirely gone away, but it is tremendously mitigated. To give you an example, over the past 3 months, say from the start of April, over 90% of our production of our facility here in Uganda has been exported out of Uganda to, for example, Tanzania, to Zimbabwe, to Zambia, and to other southern African countries, mostly overland, but also by air freight. I can give you an example where I think we'll see an increasing trend for manufacture to be located and developed to a greater extent here in Africa. An southern African nation was having, this is April, May time, severe potential challenges in sourcing its life-saving antiretroviral therapies from its usual sources of supply in Southeast Asia, India in particular, and was facing by now a stock-out situation. And for those of us who are in the HIV sphere, as it were, know that it is not at all ideal for a HIV patient to go without therapy for any length of time. Faced with this challenge, the country concerned had to look elsewhere, away from its normal sources of supply, potentially to African-based manufacturers, and we were able to step in and have so far delivered over 600,000 packs or doses of the leading or the new first-line antiretroviral therapy, a combination of tenofovir, lamivudine, and dolutegravir, thereby averting an out-of-stock situation in that country. We were only able to do that because we are an African manufacturer based, in our case, in East Africa, but focused on therapies, quality therapies, that are tailored to the diseases and conditions most prevalent on the continent. In this particular case, HIV, but also malaria and hepatitis B and what have you. So long term, my informed prognosis would be that we are going to see security of supply of pharmaceuticals and life-saving pharmaceuticals we're talking about here becoming as important a factor as quality and price in the decision-making processes of those colleagues who are in the position to purchase pharmaceuticals. So what does that mean? Well, simply, I believe that we will see more local manufacture, more investment in quality, affordable pharmaceutical manufacture in East Africa, and also more broadly throughout sub-Saharan Africa. This won't be an overnight development. It will take time, but I do believe that we will see, if not a fundamental shift, we will see quite a very significant shift into manufacture in Africa of pharmaceutical products, much more so than we have seen heretofore over the previous 5 or 10 years. What COVID has uncovered is a potentially damning and serious security of supply situation, which I do believe has been recognised, and I do believe will be acted upon. You know, in our particular case, as I was saying, in the last 3 months, 90% of our manufacture has been exported, and that is displacing supplies that previously came from outside of the continent. Going forward, that percentage will not stay at 90%, but it will remain, I would envisage, at a significantly higher percentage than we've seen before. Aligned with that, I think we'll see our peer manufacturers in Kenya and beyond experiencing a similar upturn in exports to other countries in Africa, as governments and healthcare providers generally learn from the experience of COVID and seek to mitigate the security of supply, pharmaceutical-wise, that COVID has uncovered. So where will we be in 3 to 5 years' time? Well, I believe we'll be in a position where the pharmaceutical manufacturing industry in sub-Saharan Africa is much more developed than it is now. Even if there had been no COVID, we would have seen and will see, I would have seen significant growth and development of the local indigenous pharma manufacturing capacity in sub-Saharan Africa. What I think COVID has done and will do is both deepen and accelerate that trend very significantly. Maybe in 3 to 5 years, we will be where we would have been in 10 to 15 years in terms of local manufacture of quality, affordable pharmaceuticals in Southern Africa. In addition, I think we will see the development of more sophisticated and higher technology manufacturing pharmaceutical-wise in sub-Saharan Africa. By that I mean the manufacture of sophisticated injectable products, maybe not initially biotech products, but certainly injectable products to treat cancer, oncology, and other conditions. Whereas currently, the pharma industry is predominantly manufacturing tablets, capsules, syrups, and what have you. Moving forward, I do think that we will see an accelerated impetus to higher technology manufacturing, in particular of sterile injectable products across East Africa and Sub-Saharan Africa more generally. And this again will be spurred on by the experience of COVID, which, as I say again, just to reiterate, has uncovered potentially very serious issues of security of supply of life-saving pharmaceutical products. That, I think, will be the long-term legacy of COVID. And if there is a silver lining to the dark cloud that we've all gone through in the pharmaceutical and elsewhere fields over the past 3 to 4 months, I think that will be it. But in 5 years' time, we will see a much more robust, larger, dynamic, and profitable pharmaceutical manufacturing sector in East Africa and generally throughout Sub-Saharan Africa than would possibly have been the case, or likely have been the case, if we had not gone through this trying COVID experience over the past several months. Thank you.
Thank you, David, for that very elaborate discussion. From what you've picked up and what you've mentioned, I have a question in terms of, currently we are seeing a lot of effort going to establish a vaccine for COVID. Will this create a shortage in the production of the other pharmaceutical drugs, since now all effort is being pushed to getting a vaccine for COVID-19?
Yeah, that's a very interesting question. Quite frankly, I do believe the answer would be no. Vaccine manufacture is a specialized field. There are not many vaccine manufacturers in the world, but what the vaccine manufacturers do have is tremendous capacity. Even in a non-COVID year, they are manufacturing tens and tens of millions of flu vaccinations, for example, on an annual basis. And in fact, the flu vaccination that is given actually varies. The component of the flu vaccine varies from year to year. So vaccine manufacturers are very adaptable, they're very dynamic, and they can switch on and off production very quickly. And they can dramatically increase their vaccine output in a very short space of time. But it is a specialized field. There are not many players in the world or the global vaccine manufacturing environment, but those that are there have potentially very, very large capacities, and they are able to ramp up those capacities very quickly. So I do not believe that it will impact the provision of pharmaceuticals in other sectors to treat other diseases. No.
Very well said. I can see there's so many questions coming up. I have a question for Navin, and this is in regards to any innovation that has come up in the manufacture of drugs, that have come up in the manufacture of COVID drugs. Has there been any innovative technological enhancement that has seen pharmaceutical companies adopt? Yeah.
Sure. Well, not particularly in an African context, but what we have seen, for example, is the innovative, so to speak, repurposing of drugs that were originally developed for the treatment of other conditions. For example, the drug hydroxychloroquine, which we've all heard a lot about, and we in fact have manufactured here in Uganda as part of the COVID response, was originally developed as a malaria drug, and is currently used not so much in malaria, but to treat autoimmune disease such as lupus, and also relatively severe cases of rheumatoid arthritis. That drug has been repurposed to treat COVID. Similarly, the new injectable medicine, Remdesavia, which we all hear a lot about, and which potentially could be the first line therapy, or one of, for the treatment of more severely ill COVID patients, was originally developed as a treatment for Ebola. In fact, it failed in the treatment of Ebola, but it has been ingeniously repurposed again to treat, and it would appear somewhat successfully treat, COVID. Likewise, dexamethasone, the injectable steroid, which has been available for more than 50 or 60 years, has likewise been, if not repurposed, certainly proven to be effective in the treatment of COVID. So what we have seen is given the fact that COVID has only been with us for maximum 5 or 6 months out of Wuhan or wherever, to have such a range of medicines, pharmaceutical products in the physician's armamentarium within such a short space of time is a very, very excellent development. But none of these drugs are new. In fact, it would be impossible to develop a drug from scratch within 4 to 5 months, from synthesizing the basic molecule. But where we are is that we do have greater or lesser effective therapies for COVID, which were originally developed and introduced for the treatment of other conditions, but now have been repurposed, as I say, for the effective treatment of COVID.
Thank you, Nevin, for that. We'll take questions from the audience at the tail end, and I would that we introduce now Dr. Gakombe to take us through this topic. Dr.
Thank you. I'll start from where my colleagues have stopped. One of the innovations that has also taken place is the making of ventilators. Traditionally, we've not made ventilators here, and ventilators have been made by companies that are specialized in that equipment. But across the world, car manufacturers, companies that were manufacturing other things did switch their production to actually make ventilators because there was very, very big demand for ventilators for those who are critically ill. So there's been a lot of switching of capacity, innovative use of resources to serve a need. Now, I am in two fields. One is IT and the other one is healthcare provision, because I'm involved in a hospital. And I run an IT company that does systems for hospitals. And we've had interesting experience. And some of it is local, some of it is global, some of it is fairly personal. And I think globally, the first lesson for everyone across the world is that there is no one with a complex enough or large enough healthcare delivery system to cope with a pandemic beyond a certain level. If you look across Europe, in the US, they simply didn't have enough ventilators, they didn't have enough critical care capacity to cope. And therefore, everyone has to work to prevent systems from being overwhelmed. And this is critical because post-1945, when antibiotics came into being, we increasingly focused on curative treatment and increasingly saw healthcare as something that started at the hospital gate instead of the community. One of the big lessons from this pandemic is that it is back to basics. Prevention is better than cure. Prevention takes place in the community. And if you don't manage it at that point, and the defenses get breached, then there is no one with a good enough healthcare system to cope. So if you look at what is happening in our country, we are going back to those basics of sanitizing and masks. It's basically prevention or level 1 intervention, which is at community level. The second big lesson is an observation I made many years back when I was doing my MBA, which was that the biggest threat to healthcare, to hospitals as businesses, the private ones, was actually not fellow hospitals, it was public health. My biggest competitor is not the Aga Khan Hospital or the MP Shah Hospital, it is public health interventions. If you look across Kenya, private hospitals or none, actually all hospitals, their numbers dropped in the region of between 30 and 80%. The numbers went down. Part of it was fear because we had initially the COVID pandemic, and then it was followed by a pandemic of fear, which is increasingly waning. People are scared. So some did not go to seek healthcare because they were worried that they would leave the hospital with COVID. But there was also some real scientific reason for the drop in numbers. We treat infectious conditions. And from our data, 10 to 12% of all our patients have upper respiratory tract infections. The moment people sanitize, no handshakes, masks, those numbers drop for real. Another 10% is gastrointestinal disorders, which have a fecal-oral route of transmission. And that means that if you keep your hands clean, then the number of gastrointestinal diseases drop. So by doing the COVID interventions, we have also extended those hygiene measures to a point where they have led to a reduction in infectious diseases. And if any hospital manager did not know that public health is a competitor, now we all know, because some of us have had to retrench staff, send staff on leave, and let the world know that we are suffering financially. Then in the healthcare provider environment, because of patient fear and because of the risk of passing a disease which is easy to pass because it's respiratory in nature, unlike HIV, which was essentially mainly sexually transmitted, COVID is transmitted through air, and one can get it from the next neighbor, and you don't have to be behaving badly because HIV was seen as a disease of people who were sinning, you know. But this particular one, it's difficult to attribute infection to any antisocial behavior. And so we've all had to focus a lot more within the hospital on infection control. Traditionally, hospitals did focus on infection control. It was a lot more in the critical care unit because of multi-drug resistant diseases. But as it is now, we're spending a lot more on personal protection equipment. Our staff are wearing masks. So again, the pandemic has brought to the fore that essential need to prevent transmission of disease from one person to the other and to make the workplace a lot safer. And that may well outlast the pandemic. Before COVID became what it is, we were checking how well our staff were hand washing because it's one of our safety standards. And it was an uphill task to keep people hand washing. Now it's basically ticking in all the boxes, and it shows up as green. It was a big motivation by staff to do it. Before, we used to have, we made a policy many years back to become cashless because we are in the eastern part of Nairobi and thieves like cash. Again, it was an uphill struggle until the government came up and said cash is not such a good thing anymore because of the risk of infection. And we've moved from struggling to a point where only 10% of our payments are actually in cash. And patients want to be given alternative means to pay. Most of them are paying by M-Pesa or direct money, direct transfer of cash to our bank, but mainly M-Pesa. So I believe that will outlast the pandemic. The move to a cashless economy, which has been one of the intentions of government, is something that COVID has helped push further down the line. And even for SMART, because I know SMART for a while, we thought we had a SMART identification solution for patients until issues of contact came up, and the people who are in that space yourselves had to come up with the OTP, the one-time PIN, which is contactless. And of course, if we go back to the first presentation about home care, one of the big challenges was how do you identify patients at home, and yet the biometric readers are in hospitals and healthcare facilities. And so you all had to scramble yourselves, Savannah, CarePay, to come up with a way where we could safely and securely identify people who are at home. So that is a conversation we had for a long time. It's been resolved in weeks instead of the period it was taking. And so essentially, every provider is looking at their facility to see how to minimize contact between patients, how to minimize contact with services. And it is work in progress, and I believe that is something that will be sustained post-COVID. Doctors like me are used to having people waiting for them, you know, long queues, no social distancing. Dentists are much better at giving people appointments. I guess it's a different historical basis on which the two practices came. But the concept of keeping African time is something that is likely to reduce significantly. We find that many of our clients are now keener to get appointments, keen to spend less time in the hospital. So it is no longer a good thing to simply tell patients to arrive at 9. They want a more specific appointment if they are coming to a clinic, if they must come at all. So I expect that as we go forward, innovations in queue management, innovations in bookings and scheduling will be key to every healthcare provider, because no one will want to crowd in front offices going forward. And again, and I speak for Kenya, but I think it's happened across the globe, because of the emergence of private healthcare delivery, especially in African countries, we had lost sight of the fact that government is still a very key player in the sector. We are now all having to follow guidelines. Actually, one of the reasons our numbers went down is the government said no elective procedures. And the next thing that happened is NHIF stopped authorizing elective procedures, and our surgeons were idle. So the central role of the government in policy and regulation is something that again has come to the fore. And it's clear that we really don't have an alternative to that. We simply have to strengthen our policy and regulation. We suffered a lot in the early days because of the supply chain disruption. And I think that has been alluded to from the presentation on manufacturing. We could not get personal protective equipment. For a while, masks were very rare and very expensive. And this again was global. We still cannot get kits. We have bought a machine. We've ordered equipment for tests. We can't get it until sometime in September, because the Americans are busy ramping up their testing capacity, and those machines cannot be exported from the US, and neither can the kits. So it's clear now to many countries that one needs to secure and to have strategic reserves and manufacturing capacity for critical medicines and critical medical supplies like personal protection equipment, because even if you have the dollars, you may not be able to find a source, because some other country or the manufacturing country may simply ban the export to anyone else so as to focus on home use. So going forward, I'm expecting not just the ramping up of manufacturing for medicines, but also what we've seen here, the PPEs, which are even easier to make compared to medicines. There will be a lot more local manufacturing and a lot more support from the governments because they have seen that there is a risk, and it's a national security risk. And one other thing that has become very clear, you can no longer hop on a plane and go to India or Turkey for treatment. So countries, when the chips are down, will have to depend on their own local capacity for healthcare delivery. So I also expect a lot more focus on developing in-country capacity to render care, more advanced care, more critical care, because again, you could have the money, but there are no flights, as the case has been, or there are no visas to other countries because they do not want visitors as it is now. So providers will have to do a lot more to manage capacity in the manufacturing, in the distribution space. One thing we missed was a virtual marketplace, an Amazon and Alibaba, where one could go and put their need for masks or for medicines. So we had people with supplies, and the shortages were both real and as a result of market inefficiencies, where one does not know who has the supplies. Just like right now, people don't know where there is a COVID bed which is available in a hospital. So there is an opportunity to create a virtual marketplace for pharmaceuticals, and we already have one in Kenya called MedSource. We'll need virtual places for hospital beds like booking.com, so that those who need service are more easily able to shop and find what they need without making phone calls or walking all over town. On staffing, again, we've seen with the irregular numbers and the rapid shift in numbers, permanent employment is clearly not a very good idea. So I expect the market to evolve pools of staff who are readily, an Uber type of environment where you are available on demand to work for more than one facility. We too have the same challenge of people working from home because social distancing requirements mean that those in admin have to, they can't see too many in a place. So whereas the nurses can't work from home, but we can see patients from home, our finance staff and our admin staff can actually work from home. We are holding virtual meetings like many other people, and there will be space and room to outsource non-core services like claims management, debt collection, which are really not core to what we do. And one of the things I've been wishing for a long time is electronic claims. We waste so many trees a year filling medical insurance forms that I'm not really sure somebody seriously looks at. We now have an opportunity to fully go digital. Insurance companies we had been pursuing for years to drop paper claims were able to make decisions in 3 weeks. So all they were lacking was motivation. Now there is motivation, and we are seeing a very rapid uptake of paperless claims management, which to me is good for the healthcare space. It will cut down a lot of admin costs and help to make healthcare more cost effective. And the same applies to payments. Petty cash is going away. Deliveries, we are increasingly going paperless because no one wants papers that have been touched by people. So there is a constant review as to whether papers are necessary. And of course, in terms of alternative delivery channels, telemedicine is increasingly being pushed from various centers, the healthcare facilities themselves, the patients who don't want to come to hospital. And some areas are easy, much easier to do. One is radiology. We took up teleradiology quite a while back. It's now our mainstay. Dermatology, because with a camera you can show the lesion to the doctor. Telemedicine is easy, but certain conditions, of course, it's difficult to do treatment from home. What is holding us back is that quite a number of payers, especially insurers, are yet to approve and authorize telemedicine. For individual patients, or self-paying patients, we are fortunate because M-Pesa has made it possible to telepay and teleconsult. Because before, one of the challenges with telemedicine was how does the service recipient pay for it? Because we didn't have good electronic payment systems, but that is no longer a problem. We have many digital channels for payments available. And yes, we did see something about chronic care, patients getting home visits. And one big opportunity that we ourselves have taken is delivering medicines to people at home. We've done a lot of data mining to identify all our long-term patients, cluster them into diagnosis, look at the medicines they use, call them, email them, and arrange for home delivery. And we were actually asking ourselves why we hadn't done it before, because the uptake has been quite good. We are delivering medicines as far as Meru, Muranga, Nakuru, and those patients didn't have to come all the time to pick them up. It was an opportunity waiting for us to take up. COVID has simply provided the impetus for us to do it. So I see us moving a lot more into the digital space. We are looking at artificial intelligence. We are looking at machine learning. We are looking at patients doing home monitoring, because one of the reasons people come to a health facility is you have to go to take their temperature and take their pulse and take their blood pressure. Those are things that can be done from home or can be done remotely. So as we get better monitoring devices, then the need to come to the doctor, remote monitoring devices, there'll be less need to come to the doctor, because one of the reasons people come to the doctor, actually a major reason, is because somebody has to examine a patient to elicit the symptoms before deciding on treatment. If it is possible to elicit those symptoms and get the tests from a distance, then the need for physical contact reduces and it becomes easier to do remote diagnosis and treatment. Thank you.
Thank you so much, Dr. Gakombe, for that very precise discussion. There's a question that has come up. Allow me to just read out for you to what you have mentioned lastly on the use of data.
Yes.
And someone is asking, what is the level of data analytics in the private healthcare? Are we now using data to advise treatment protocol, treatment engine, and such kind of items?
The answer is that there is not much. The use is still very rudimentary and very limited. There is lots of room for growth. Right now, the key use of data, as I know it, is basically to identify patients who suffer from particular conditions. We are using systems as guides for what protocols to use. We use a system called UpToDate, which all our doctors have access to. But the next level where there is, you have, the computer is basically equivalent to a doctor's assistant or doing almost as much as a doctor. We aren't there yet. There are certain, for example, a CT scan is able to do TB diagnosis. It's got algorithms that you not only can take a CT, but it will also give you a diagnosis. And the ECG machines that will also give you automated diagnosis. But that is still in the early stages in this market, with lots and lots of room for development.
Thank you for that. Probably I'll also come into what you have mentioned in regards to the adoption of telehealth by the insurance or the case management across East Africa. Probably from your perspective, what has been the major hindrance on taking up telehealth?
One, insurance is by nature conservative. And my experience is that when something new comes, they first make it an exclusion. HIV came exclusion, terrorism came exclusion, until they study the market and they figure out where all the things are. And then they say, now we have, and it came up in the first presentation. Now we understand the risk. So we have priced it and we'll cover it. And my experience so far has been the fear of overutilization and the fear of identification of members, because so far the system has been provider-based. So by opening it for people to be identified at home, basically means there are only 2 people involved and there is a higher risk of fraud. So it's an unknown. So some have picked it up, others are still studying. And of course, there is an incentive in the sense that if people come to hospital, if people can't come to hospital, then insurance claims have seriously gone down. Our reduction in numbers has also meant a reduction in insurance claims that are going to insurance. But the biggest reason I've seen is the fact that this is new, it's not been understood, it has to be priced. It wasn't priced when policies were renewed. So it requires time to make decisions.
Very well said and put, Dr. Gakombe. I'll ask one question, then I'll go to the question from the audience, very many coming in. You spoke about PPEs and ventilators. And indeed, we have seen with the COVID situation, companies who are not producing such, like Formula One, are now producing ventilators. Is this going to be short-lived, or will it create another business line for such institution, even after we open up the markets and we hopefully find a vaccine for the current pandemic that you're facing?
Okay, let me say this. The world, because of marketers, and I'm sure there are some on in this discussion, has also had a pandemic of complexity. We've made a lot of products which can work in a very basic form, highly complex. And a good example is the car. A car is basically 4 wheels, an engine, 4 seats, and a drivetrain. But if you look at a modern car today, it is a computer on wheels. And that then means that product becomes significantly more expensive. A ventilator is a fairly basic piece of equipment. But because many come from the West, they have become extremely complex machines. And with that complexity, it means the cost goes up. The ventilators used in Metropolitan have an autopilot. They actually respond to the patient's breathing. And that means you have to pay for that complexity. So I expect that we will, in many areas, will begin looking at what are the basics necessary. What is the minimum denominator for something to be safely done? Whether it is in the staffing for healthcare facilities, or even what you are calling a hospital. We've started using schools as isolation centers. If we don't lose that and we increasingly focus on the basics that are required, then it should be possible to make basic ventilators, for that can meet the needs of quite a number of patients outside the people who are known to be in the business of making ventilators, including making them here in Kenya, because the basic functionalities are actually quite basic. It can be done by engineers right here in this country, and it's been done.
I'll take the last question from me, then we'll go to the participant questions, very many coming in. And in terms of the preparedness, Dr. Gakombe, is the country and is our healthcare systems now well prepared to be able to address should a similar pandemic or even worse pandemic reoccur again? Are we now well prepared, or will still have this kind of challenge you're currently facing?
It's hard to tell right now, because right now we are still in the middle of COVID. We don't know what will remain after we've managed to, after we flatten the curve and we go back to normal. If we are not careful, we lose all the lessons and revert to business as usual. And when the next one comes, all the lessons learned, or many of the lessons learned, will have been lost. So it is very, very important for those of us who are in the industry to ensure that the residual value that remains is significant. Clearly, there are certain arrangements that we should be able to sustain going forward. We now know we can use schools and colleges as isolation centers. We have figured out that we don't have enough capacity, so now we have home care guidelines that will become the norm going forward for quite a number of conditions. We are back to the basics of hygiene, which Florence Nightingale was advocating during the Crimean War. So those I don't think we'll lose, but it's going to be active effort by countries and communities and professionals to make sure that we do not revert back to the way things were before COVID. And to figure out that we now have to worry about viral infections, because bacterial infections used to be our big worry. Viral ones, we got vaccines and thought we had sorted out measles and polio and other diseases through vaccination. It's now clear that because of a connected world, it is possible for a virus to spread very quickly across the world. So I expect ramping up of the capacity to make antiretrovirals and ramp up of public safety, health safety guidelines to make sure that prevention of infection transmission remains at the fore across the world.
Thank you for that. I know I will call upon Judy to help reading out the questions. But before Judy comes up, there's one question for Nevin in regards to drugs and specifically the vaccine for COVID. Are we seeing a possibility in terms of the manufacture and ensuring that this vaccine can be given for free or even covered through insurance?
Yeah, sorry. The question related to the cost of the vaccine and whether it would be free?
Yes, or covered, taken up by insurance.
Well, I can't really personally comment on whether or not it will be taken up by insurance. I guess that's something for our insurance colleagues to answer. Of course, no vaccine is free to manufacture. Every medicine has a cost of manufacture. So there will be a cost associated with making the vaccine available. The question will be, who is going to bear that cost? Will it be the patient or the person, he or she or child being immunized? Will it be the state? In other words, will it be provided free of charge by national healthcare providers? Or will there be no provision or no subsidy from state healthcare providers, and the cost then will have to be borne by the patient or by their insurer? But given the volumes of COVID vaccines that will be manufactured, if we do have a successful vaccine, and here you're talking not just about tens of millions of vaccination doses, but potentially hundreds of millions of doses. And as we all know, in manufacture, economies of scale mean that the individual unit cost is that much lower. Obviously, it costs a lot less to produce 100 million doses of a vaccine per vaccine dose than it would to produce 100,000. So my guess would be that the individual cost of a COVID vaccine, given the fact that the development cost to a large extent has also already been subsidized by governments and donor organizations, would be relatively low. Whether or not the patient would be required to pay for that, I couldn't say. My guess would be is that in most countries, the vaccine would be made available either free of charge through donations or at a very low and subsidized cost if the patient has to pay at all. Thank you.
And thank you, Nevin, for that. We'll go to questions now. A number of questions coming in on our chat. Judy, do you have any question there?
Okay, it looks like telehealth or telemedicine has picked up quite a bit of interest. And there is a question here that is telehealth available so I get care virtually or be seen by a doctor over the internet? Rosalind, would you like to pick?
Yeah, so a lot of insurance companies have telehealth providers now, right? So I think what I can do is urge our listeners to review their policies and just find out who their telehealth providers are. But this is an offering by a lot of insurance. I do know Dr. Karangaita has said that insurance companies tend to be very conservative and very traditional in their thinking, but it does look like on this particular one, they have quickly adopted it and the solution is widely available. So you'll have to check with your service, with your insurance company or your insurance broker, who the provider would be.
Thank you, Rosalind.
Yeah.
Indeed, there is another question that's related to that. And I'd like to pose this question to Esther. What is smart applications doing at home care, using the smart cards to pay and for the delivery of drugs? Ideally, a complete hospital visit from home while using a smart card.
Thank you, Judy, for that question and for the person who asked that question. What SMART is doing is to be able to quickly adopt the use of virtual treatment. They can be able to, through the OTP that we have recently introduced, a member can be able to easily access treatment virtually without having to call for a card, but have an app on the phone through the SMART app. I can be able to get treatment. So this is all in line with our roadmap to ensure we can have virtual treatment for all patients at all times.
Okay, Esther, I would like to also give an example in terms of what's happening in Uganda where we are at. Through the insurance companies, they have adopted a number of telemedicine providers, and they're able to provide treatment by phone or WhatsApp form that enables the client, first of all, to reach out, and the doctors are able to call back, assess the situation, and when they come and visit, then the billing process takes place at a member's home, which ideally means that the member would still be able to present their smart card and obviously validate their name while they are home, and all the investigations are done. So there is an entire cycle there in terms of how the smart cards actually is in providing the telemedicine. So the consultation follow-up are done by the telemedicine provider. And in cases where the doctors make an assessment that a particular condition requires visit to the hospital, then advice is given at that point in time so that the member can take up the care at a facility where physical examination is required. Thank you very much for that. But another very question here about private doctors' fees, apparently starting from about 6,000 Kenya shillings, but insurance companies have caps. The doctors are also on panel, if fees are too exorbitant. So I believe this is a two-pronged question. Can be put to both Dr. Gakombe and Rosalind. Why are these fees that high?
Right. Fees. The question is why doctors' fees are very high.
Yes.
The first for Kenya is that somebody sat down and asked doctors what was customary and traditional, and that became the price guide. Okay. And many rural doctors were not asked that question. So the answers provided means that we have a guideline for the medical council for fees. And some of the fees are not friendly. The second reason is that healthcare is in a sense a closed market. Consumers do not know the price. There are a lot of things you can go on Alibaba and get to know the price of a wheelbarrow or the price of a car or a boda. But in healthcare, we do not have what I may call an open market. So whereas, for example, the price guide has a visit at 6,000 for certain specialties and 10,000 for inpatient, our price here at Metropolitan for the same doctors is 2,500. But until one can advertise freely and there is a marketplace that I was talking about where you can go and shop for a doctor who is qualified. So we have to make sure the pool is vetted and qualified doctors. You can go and shop for a hospital bed. in a hospital that is qualified and accredited, it means that you have a skewed market, and therefore, that demand and supply does not work very well. So there's a market failure, and that market failure can be addressed by technology. The same way today, if I'm looking for a hotel, I was looking for a hotel some time back, and I was able to book a hotel in Manchester from the comfort of my house. And when I arrived there, it looked like the hotel I had booked, and I didn't have to go through agents, and I could pick prices from various options. We need that in healthcare, because then patients, consumers will have access to know what's available and at what price, and we therefore reduce the market inefficiency. And insurers are trying to address that by discussing packages. Right now, we are in discussions with a number of insurance companies who no longer want a fee-for-service model. They want a capitated model where we charge a fixed price for an outpatient visit. NHIF is actually in the lead, and there are a number of insurance companies that have negotiated similar packages with providers. And that then means the provider is the one to manage the cost of the doctor's fees plus the other inputs. Thirdly, part of the reason our healthcare is expensive is that I don't use the term overutilization. There is inappropriate use where something that can be done by a nurse, immunizing babies, can safely be done by nurses. Now, if somebody chooses to go to a pediatrician for immunization, then it costs the price of a pediatrician, not the price of a nurse. So part of what we need to do is start shifting to make sure that services are provided by the least qualified person who can do it. There are certain jobs nurses do that can be done by community health workers. So we have to look at the whole service hierarchy and really plug each service at the point where it can safely be done. And one good example is midwifery. Nurses can safely deliver 80% of births in most countries, right? Many patients opt to go and see an obstetrician. And of course, it costs significantly more because the obstetrician is a scarce resource who has spent more time learning, so it ends up costing more. So those are some of the reasons that prices may be higher than they should, and the things we need to do to address it.
All right, Judy, did you want me to say something?
She wants you to talk for the insurers.
Okay, good. So I think Dr. Gakombe has sort of alluded to what the issue is, that insurance is also working within the confines of a very closed market. They're also guided by a rate card, which is done by the Kenya Medical and Dentist Board. So there's also a lot of pressure for insurance companies to give a good mix of service providers, the high and the low end. And if you look at the listing of service provider that you have gotten, you will realize that therein lies some very well-priced service providers. So not everybody is exorbitant, not all service providers are expensive. It's just that there's a very good mix. And one of the things that insurance is aiming to do is give you choice as a member. So yours is to be very pragmatic with your choices and make sure that you can stretch your benefits as much as possible, as far as possible. Doctor said that in his very own hospital, that the pricing is lower for the very same physicians, and that is a testimony that there's a very good mix of providers on your panel. So I'm asking that particular member to maybe just review that panel, and I'm sure therein will lie a few providers who are very well priced. and also an opportunity for them to stretch the benefits to, to the whole year. All right.
Thank you, Rosalind, for that. There's one question for the doctor in terms of what effect does COVID have to companies adopting new solutions?
Clearly, for many employers, we have to think about workplace safety a lot more. We have an Occupational Health and Safety Act in Kenya. We have WIBA, but in my experience, in a lot of places, we've not paid too much attention to airborne infections. We've looked at injuries and falls, and a lot of focus has been in factories, because factories are more likely to suffer physical injury. So the focus I've seen is in companies looking at how do we reduce the risk of infection within the workplace. And that has meant digital meetings or virtual meetings like the ones we are holding, people working from home, institutions not wanting any papers, introducing sanitization. So it's basically viewing occupational health and safety and giving it a lot more weight than it has previously been granted. And I think those of us in jobs and those of us who are employers have an opportunity to seriously focus on workplace safety now that COVID has forced us to cast a spotlight in that area. We should go beyond COVID and ask, what else is it that we could do? And I think it's also important to look at cost, because COVID has shown us how expensive a healthcare problem can be to, or an infection can be to an economy. And I think those smart, metropolitan, and those of us in the healthcare space, we need to start sharing data with employers to show how much they spend on conditions that are preventable. Because in a lot of places, when one person has a flu, they go on and infect half the office, and the bills all end up going to the insurer, and the next time you want to review your premiums are higher. So if the cost were to become clearer, as COVID has made it the case, then it's likely that organizations will see payback and value in better managing the environment.
Thank you, Dr. There's a question here for all the guest speakers. I would want to pose it to all our guest speakers. It's about public health being a threat to the private sector. And the question is that what is the public health system doing wrong, since they're still unable to get the masses despite the effort? So I want to get from the speakers this afternoon.
From where I sit, we simply thought we had an alternative. Because if you study the history of medicine and healthcare, in the 70s, when we did not have CT scans and MRIs and ICUs and all these things, we focused a lot on clean water, on getting rid of bed bugs and fleas. Basically, we focused on public health, on making sure the shops were clean, the abattoirs were meat was inspected. But towards the 80s, 90s, and to the 2000s, as we built more complex healthcare systems, and doctors studied more and more medicine and became neonatologists and neurosurgeons, we forgot that public health was still as important as it had always been. So it's more a fact of focusing back on basics, and the leadership in the Ministry of Health being people who have a public health orientation. Even if they have done medicine, they must be looking at whole of country instead of focusing on, whenever we talk healthcare, the focus is on hospitals. And of course, from a political point of view, there are not many marks in doing public health. There is more drama in visiting an ICU to see a patient who was, like the babies who were separated in Kenyatta, and it was the first such operation in East and Central Africa. There is more political mileage in the photo op. So we have to refocus and get our political leadership. I think COVID has shown them that a pandemic like this poses more political risk than many other problems in a country. So hopefully the opportunity will not be lost to focus, because we have the capacity to focus on public health. We just have to make sure we deploy that capacity in that direction. And that includes private insurance companies. We all must invest in prevention, because the alternative is that it costs a lot of money to everybody concerned.
Definitely, I would agree with you, even as I bring up Nevin to give his response to that question. But from what we have seen, only this one public health issue that we have faced of COVID has completely disrupted the entire economy, be it transport, be it agriculture, be it every aspect of the economy has come down by a health situation. So just to support what you are talking about, Dr. Nevin and Rosa, we want to get your views on what is wrong with the public health.
Well, I think obviously in terms of the qualifications and experience of physicians, that is similar in the public and private sector. But looking at the funding of the private sector, the public sector, that obviously is a major issue. Funding of pharmaceuticals, funding of facilities, and the general standard maintenance, wear and tear, and what have you of public healthcare facilities. In terms of obviously convenience, in terms of convenience of accessing public healthcare versus private healthcare, then quite frankly, there's no comparison. Obviously, private healthcare, you're paying for possibly the same physician or a physician of a similar experience and academic and what have you standing as the public sector, but you're gaining access by and large at a time and place of your choosing and convenience. You're not accessing public healthcare facilities and queuing up for hours and hours. And at the end of that, protracted, painful process, possibly being diagnosed or treated in facilities which are markedly different from the private sector, unfortunately. And the basis of all this is funding, or lack of, or not enough. And as the doctor has said, one of the long-term lessons, takeouts from COVID, is that the public healthcare sector generally requires increased injection of and significantly increased injection of funding from central government. If you look at the recent budget that we saw here in Uganda, for example, which took in effect from the 1st of July, the increase that was devoted to the Ministry of Health was very, very disappointing when compared, for example, to the significantly larger increase in funding we saw for security and other arms of government. And until healthcare becomes an equal priority with some of the other arms or areas of government spending, then I think the public healthcare sector is still going to be limping along for the foreseeable future. The facilities, the convenience, the queuing, the lack of pharmaceuticals, the lack of treatment options, the basic root cause of all of that is funding or lack of, I would suggest. Thank you.
Thank you, Nevin, for that. Rosalind?
All right, Esther, I think that's a very good observation. We are required to do more when it comes to public health. And for Kenya specifically, we need a very strong public health system, one that is very deliberate on reducing the burden of illness for the public and one that is very deliberate in improving the function of health when it comes to our people. And we have also said time and again that with this pandemic, the interaction with the environment has been brought to question. So there's a lot that is required in terms of optimizing the health of Kenyans. We need preventative services, and we think that the government, in conjunction with insurance companies, has to be very deliberate on preventative services and on mental health services. If I had to put out the position of insurance when it comes to some of these things, such as preventative care and mental health care, we have seen a considerable uptick. There's a lot of insurance covers now that will cover for medical checkups. They will cover for psychological, psychiatric issues. They're reinforcing counseling and therapy as an option, something that we did not see in the past. I honestly think the problem we have is a lack of awareness and education for our members, for them to appreciate that the insurance companies do more than admitting them and them just getting day-to-day outpatient services. The government has to to be very deliberate on making sure that for this to work, they must give us a quality workforce. They must provide financing and very deliberate financing. Very high budgets should be allocated to healthcare. Information and awareness has to be a very deliberate attempt. I think they have done very well in the recent past when it came to this particular pandemic. But I think we need to do more, even when we don't have a situation such as this or a crisis. We need to do more in educating the public. And also the one thing that I would challenge both the private and the public sector is to do more when it comes to preparedness for emergencies. I think we just need to increase our level of emergencies. We need to do more. I want to applaud the government for doing their very best in this particular one. We have felt their input, but I honestly think that more could have been done in terms of getting us ready for disasters or emergencies such as this.
If I may add a couple of points.
Yes,
The first is we have an opportunity. You know, the new constitution separated policy, regulation, prevention from curative services. Because traditionally part of the problem has been that when they were all together, resources were spent on curative care. So what we need is to make that separation work. The idea of handing over the curative care to the counties and we maintained the policy, regulation, and so on with the center is not bad in itself. It's actually quite inspired because when the prevention and curative subsystem are put together, the focus is always on the curative, which is more urgent, more dramatic, more, photogenic, and so on and so forth. So part of what you've seen is actually the benefit of that. The CS has no issue with curative services. That is the job of governors. So he has focused a lot on prevention and guidance and policy. The thing is to get the counties to work, even if we have to jail every single governor to get the message across. Secondly, healthcare has moved from the backyards of government policy and thinking to Agenda 4. I speak for Kenya when I say what we need is also to hold our leaders accountable, those of us who are in positions of influence, to truly make it work, because at policy level, and at political economy level, it's been recognized that it's one of the 4 main things that we need to contend with. The execution is now the challenge. So we again need to push that. We simply do not want to see it as Agenda 4. On paper, we want to see it in practice.
Thank you so much, Dr. Kakombe. A number of questions coming in on home care and the insurance sector, Rosalind, in terms of, with the concept of home care be fully endorsed even after COVID. And this is something that the insurance companies will be able to pay for. and actually encourage, as opposed to what we call in hospital treatment?
The concept of home care has been endorsed by insurance companies for a very long time. And that is why I'm beginning to think that the problem here is awareness and the information that we are giving our members in terms of coverage. What are we telling them? And what can we do to make sure that they can stretch their benefits, they can optimize their insurance solutions, the insurance covers. Home care has been endorsed by insurance companies. It is not new, it is not foreign. Actually, home care has also been encouraged, especially for some cases such as physiotherapy, cancer, where you're managing a long-term ailment. Home care has been encouraged as a step-down option by a lot of providers. So where you have a very long admission and your finances are running out, more often than not, if you have a good intermediary, a good broker, they're going to tell you that you have step down as an option. And usually step down is either you go to a facility that is cheaper, or you get home care so that you can be able to manage the benefits that you have left. So these are solutions that already exist. And I do think the gap that I see now is a gap of awareness and information. So I think that is something insurances are endorsing. We now have to ask our listening public if they have had an opportunity to totally optimize their insurance covers. Are they getting the best from the premium that they are paying? So you need somebody who can be able to walk that journey with you, somebody who can honestly tell you that your insurance can give you more for the premium that you pay. So home care is not foreign, it's not new, it has always been there. And I'm urging our listeners today to maybe go back, take a step back, go back to their HRs, look at their policies and ask if some of these things are already covered. But you will find that for a lot of people, these benefits already exist. Okay, Esther?
Thank you, Rosalind. I'll take one last question from the audience before I give all our guests to give their parting shots. And this is for both Nevin and Dr. Gakombe. And somebody's asking about the comparison between Kenya, Uganda, and other advanced countries like South Africa. A question comes in terms of what is Kenya doing to ensure we do not reach a breaking point like we have or we will be getting into with this COVID situation, whereas we have seen countries like South Africa actually testing a vaccine already in this continent. So what can we do as a country, both in East Africa, that is Uganda and Kenya, to ensure we do not reach a breaking point?
The first thing I want to say is Kenya has been very, very key in vaccine development. So it is highly likely that to be heavily involved in any vaccine for COVID, because HIV, we are right in the middle of it, and we've continued to be in the middle of it. So it's not a new thing, and that's what Kemri was trying to say. We have prior experience which can be applied. Senegal in West Africa has experience with Ebola, and actually when COVID initially happened, we went to Senegal to learn because they have a very, very good institute there. So Africa will be right in the thick of the vaccination agenda, even with all the conspiracy theories, because we've been key in the vaccine drive across the world for a long time. Two, the only way we'll avoid being overwhelmed is if we manage this problem at community level. Our 500 ventilators, I just bought 2 yesterday. Those are a drop in the ocean. So the only way is for us to stick to those guidelines and be our brother's keepers, because the reason vaccines tend to be free to the public and the government's pay is actually the payback, that by getting rid of the disease in the community, then you keep everybody safe, and it becomes a very, very useful investment. And you've seen every time measles flares up, it becomes very expensive, because when a good number of people get infected, it's very expensive to the community and to the government. So it is in everybody's interest. It is in the public interest to do everything possible to prevent infection. So it is you and I to follow the guidelines so that we don't go to hospitals.
Thank you, Dr. I can see we are now almost at the tail end to our time at 4 p.m. We still have a number of questions coming in. We may not be able to answer all of them in this session, but we'll ensure we take up the question and respond through our guests to each one of the questions coming in. I'll allow our guests to just give their parting shots. We would not want to surpass our 2 hour to close by 4. So I will allow Rosalind to go first, Nevin, and then Dr. Gakombe.
All right. So I think there's generally a feeling of hopelessness in this situation, and that is what is coming through. But I just want to reassure the public and our listeners that I think there's a lot of solutions and a lot of things that you can do from your end to make sure that you're either covered as an individual, or your corporate or your organization is covered. I did allude earlier to a keen look at your employee assistance program, and more so, does it address chronic management? Is there a thorough program for people who are facing chronic diseases? Is there a thorough look at the mental health of the employees? Has substance abuse been taken into account? And all this these are the things that we are seeing coming through at this time. I think that another thing that I have sort of taken note of is that there's need for greater awareness on what insurance does cover and how insurance responds to pandemics or otherwise. And maybe just to urge the listeners to take a keen look at their policies. And if they can get somebody, maybe a middleman, to sort of interpret those policies for them and show them how they can optimize their solutions. So some of these things, such as telemedicine, telehealth, drug delivery, home care, these are solutions that are available, I think, with almost every insurance company. But you also have to be very careful to make sure that your policy wording does respond accordingly. Finally, we need a renewed focus on public health, because we need to take care of the general masses. I think that if we can take care of the public health, then universal healthcare will be something that we can easily achieve. We have spoken about universal healthcare for a very long time, and the time is right. The time is opportune for us to make sure that that agenda does work. Just one last one is that for anybody who's working on a return to work policy, let them take a good look at the document that has been set out by the government on occupational hazards. Take a good look at your WIBA policy and see if the coverage does extend to occupational diseases and exposure to COVID-19. There's a lot of tricks and hacks in terms of pairing your current WIBA policy to what I call a personal accident policy for your staff, so that you can make sure that your staff are covered 24/7. Because ordinarily WIBA would cover you during working hours, but once you pair it up with GPA, which is a group personal accident, then that extends their coverage to 24 hours. Thank you very much, Esther.
Thank you, Rosalind, for that. Very well put. Definitely for all of us who are insured and for all our participants, the message is to go back and look at our document and see if they have these fine prints on the items. Allow me to welcome Judy. It's a question that we'd want to go through. So Judy, even as we come to the tail end.
Esther, thank you very much. I would like to give Nevin an opportunity to also give us his parting shots and also just to give us a highlight on the role that CIPLA has played in terms of lowering the cost of.
Yeah, thanks, Judy. I suppose currently we don't know if we're at the beginning of the end of the COVID experience or the beginning of the end. I would say either way, we cannot afford any complacency. If we are at the end of the beginning, then we have some considerable way to go. Or if we are at the beginning of the end, then the way may not be so long, but still possibly fraught with many challenges. And in either scenario, I don't think we can afford any complacency in terms of, social distancing, sanitizing, and all the measures that we have employed for the past several months. I would agree that one major takeout from the whole COVID experience is the need for a much greater focus on public health care funding. Actually, the responses in Uganda and Kenya in particular, maybe not another neighbouring country, but Kenya and Uganda, in the world context, have been, very, very good. Maybe it's because of the experience of tracing and Ebola and what have you. But if you compare the initial response to that of certain European countries, it has been much more speedy, much more focused, and much less, quite frankly, chaotic. In the European context, we see some countries changing their policies, not changing the rules, changing the lockdown rules almost on a daily basis. And we've certainly not experienced that here in Eastern Africa in the May, with obviously one potential exception in a neighbouring country. But overall, the major takeout must be that public healthcare spending must be a much higher priority in the minds of legislators, finance ministries, and those who are setting the budgets for public spending as a whole going forward. A lot of the response in Uganda, certainly, good as it has been financed by donations or public mobilization, allied and alongside the response from the Ministry of Health and the public healthcare arena. But if the public healthcare arena had been much more broadly and deeply funded, then some of the challenges that have been faced could have been avoided and will be avoided in the future. And not just in COVID, but across the whole parameter and paradigm of the delivery of an effective and comprehensive public healthcare system.
Thank you so much. Thank you so much, Navi. Dr. Gakombe, your parting shots.
Thank you. The point I think I would wish to part with is that we have the basic foundation for transformation, and that every time the world has gone through a crisis, human beings have faced a choice. And the choice is to ride over the crisis and emerge much stronger, or to lie back in hopelessness. And if you look at one of the biggest challenges the world has faced in the last 100 years, it was Second World War. And it is out of that the UN was born, aviation as we know it was born, medicines as we know them were born. And COVID presents a similar opportunity. First, we have learned that no one has perfect systems, so we should look a lot more inwardly to find solutions, because clearly Italy, the US, the UK have challenges too. And even as we learn from them, it is learning, knowing that they have not perfected the solutions. Because there are many times in Africa, we look at the West and we think all the solutions are there. COVID has said it isn't. We also need to look and develop our own solutions that can work within our context. So my challenge is to each of us. There will be before COVID and after COVID, and life won't be the same in every industry in the way we do things. For each of us to look at the foundations we have, whether it is M-Pesa or the fiber optic communication or the opportunity to manufacture, or the fact that the world will, I don't think, use China as the world's workshop because of the issues that the world has faced getting access, and utilize that as an opportunity to better ourselves, our organizations, our country and continent.
Thank you so much, Dr. Gakombe, and our guest speakers. We now want to close the session. It has been a very thought-provoking and powerful session. We were at a high of 175 participants who were able to join us and hear us through this call, as well as on our live YouTube channel. Allow me to appreciate all the guest speakers, Nevin, all the way from Uganda, Rosalind and Dr. Gakombe, and of course, Judy, our host. I now want to close the meeting. For the team, we will respond to all the questions which have been shared with us on the chat, and we'll direct that to all our guest speakers, and we will ensure we give a response to each of these. So thank you so much for your time, and definitely keep safe, continue keeping safe. Thank you.
Thank you.
Okay.
Bye.
Bye.